We are, you now know, we are recording this. So we did get some queries. So please, any of your colleagues or friends who've not been able to be with us, please let them know that we will be making this available. But a benefit of being here in person with us is the opportunity to engage and ask questions and really kind of just more deeply engage with us, which is what we want. We'll be monitoring the chat and looking for hands going up and trying our best to accommodate engagement from the audience. And so my name is Sabra Klein. I am a professor of molecular microbiology and immunology at the Johns Hopkins Bloomberg School of Public Health. I am lucky enough to co-direct the Johns Hopkins Center for Women's Health, Sex and Gender Research with my friend and colleague, Dr. Wendy Bennett, Associate Professor of Medicine at the School of Medicine. And we have been working with several of our colleagues, including Rosemary Morgan, Dr. Rosemary Morgan and others, to try to really bring together and start to really develop what we're calling a sex and gender community of research and practice here at Johns Hopkins. And a part of this is going to be annual educational opportunities. This year, we opted for an educational opportunity that we've called Meet the Methods, incorporating sex and gender analyses. And we based this on our close friendship and a collaboration with our Canadian colleagues, including Dr. Cara Tannenbaum, who I'll be introducing momentarily. Funding for today's educational opportunity have been provided by our Johns Hopkins Specialized Center of Research Excellence. So that's our SCORE, funded by the Office of Research on Women's Health, as well as the National Institute on Aging at the NIH, as well as the Foundation for Gender-Specific Medicine, led by our friend and colleague, Dr. Mary Ann Legato. Next slide. So today we are lucky enough to have Dr. Cara Tannenbaum give our keynote. And before I introduce her, I want to say that she will be speaking and answering questions within the first hour of this webinar, which will then be followed by 3 very short instructional presentations by investigators here at Johns Hopkins, including myself, focused on basic science, Dr. Rosemary Morgan, focused on gender analyses for health research and interventions. And this will be followed by a tag team effort by Drs. Wendy Bennett and Jay, that I think it's Vaidya. I'm hoping I'm pronouncing your last name.
Vaidya is more or less, that's right, Vaidya.
Thank you. On sex and gender intersection in clinical and epidemiological research. So if we could pull up Dr. Tannenbaum's title slide, I would just love to take a moment. I am thrilled that Dr. Tannenbaum agreed to join us for this educational opportunity. And this concept of Meet the Methods really came from work that she and her team have been doing at the Canadian Institute of Health Research. Dr. Tannenbaum was appointed scientific director of the Institute of Gender and Health at the Canadian Institute of Health Research in 2015 and currently serves as departmental science advisor for Health Canada. Dr. Tannenbaum is a professor in the Faculties of Medicine and Pharmacy at the University of Montreal, and she is the recipient of so many prestigious awards, including but not limited to the May Cohen Gender Equity Award from the Association of Faculties of Medicine Canada, the Canadian Trailblazer Award for exceptional contributions to science policy, and most recently, her receipt of the prestigious appointment as a member of the Order of Canada, one of Canada's highest civilian honors. Dr. Tannenbaum provides internationally recognized leadership on the integration of sex and gender-based analysis, considerations in research, practice, and policy. She champions the use of data to drive decision-making for increased representation of sex and gender from an intersectional approach among those not only who conduct the research, but those who benefit from scientific research as well. Dr. Tannenbaum obtained her medical degree at McGill University and subsequently obtained specialized training in geriatric medicine and older women's health. Her fellowship included clinical training in women's health and osteoporosis at Mount Sinai Hospital in New York, a master's degree in epidemiology and biostatistics from McGill University, and research training on sex hormones at the University of California in San Diego. It is with pleasure that I welcome Dr. Tannenbaum to talk with us today about whether our research is at the cutting edge of sex and gender science. Dr. Tannenbaum.
Thank you so much, Sabra. I am so excited to be here with you, and congratulations to all of you for showing up and wanting to be at the cutting edge of sex and gender science. So I find that Zoom talks are so not as exciting as being in person. We couldn't be in person, but I'm going to ask for your help to make this as exciting as possible by starting off with a few questions that I'm going to sort of insist that you write the answers to in the chat. Next slide, please. But before I begin, I wanted to acknowledge that I'm speaking to you with gratitude from the traditional land and unceded Indigenous territory of the Anishinaabe here in Canada. I use the pronouns she, her, and I also want to acknowledge and recognize my white cisgender privilege. I offer humility and an openness to learn as I'm continuously learning about intersectionality, having not had lived experience of racism, gender diversity, and various other forms of marginalization. So I'm hoping that some of you can help me and teach me, and that this could be kind of a bi-directional conversation. Next slide, please. My goals for today are really to invite you to reflect with me on one, what you can do to ensure that sex and gender science are incorporated in your work, but I'm a big advocate and champion. So I'm also going to invite you to reflect on what you can do to ensure that others are incorporating sex and gender in their work, because changing culture takes everyone. And finally, we're going to think together about how we can make sure that the findings from sex and gender science benefit everybody. Next slide, please. My first question to you is self-assessment. And here's where I want to see you put numbers in the chat. The question is, on a scale of 0 to 10, 0 being not at all confident and 10 being extremely confident, how confident are you that you are incorporating sex and gender science in your work in a cutting edge fashion? All right, thank you, Jacqueline. I see a 6. Bernice says 5. Deem, oh, Jen is 8. Whoa, Sabra, okay, you're a speaker. 9, you organized this. Thank you for your honesty. I see some of you are putting 2. I see some 4s. I'm trying to enter this quickly in a calculator, but I think we have an average of about 5. But I like the range, because that means that, you know, those of you who do science, of course, you don't want to start with the ceiling effect. If all of you had said 10, then I would really have to up my game on this talk. But for now, I feel like, you know, we could cover some basic concepts. So next slide, please. My second question that I need you to answer is, in which fields of work do you wish to have impact? I didn't put numbers here, so you'll have to type. Are you working in basic science? Are you more clinical research? I see public health, medicine, public health, clinical research, public health, nursing, clinical, epidemiology, medicine, translational science, that's a good one. Epi, good, community services, public health. A few basic science, not too many. I think mostly we're looking at population, public health, health services, nursing, medicine, and a few basic scientists thrown in. Ooh, I like implementation science, Courtney. That's actually one of my favorites. All right, good. So I think that we have something for everyone, but you'll tell me at the end, or you'll ask me a question if we didn't cover it. On to the talk. Next slide, please. Now, you're at Johns Hopkins University. I'm assuming that you're very smart and very savvy and that you already know a little bit about sex and gender. So you'll tell me if I'm right. Next slide, please. My first assumption is that you already know how to use the term sex and gender correctly. Is that true or false? And actually, I'll show you the slide. I think it's the next slide where here's the big test. So true or false, the terms sex and gender mean the same thing and can be used interchangeably in health research. Now, those of you who put anything above 7 on how confident you are, don't answer this one because that's like, okay, I see you're all answering false. So I'm guessing that some of you, who was it who put the 2? Like, you know, I kind of like if someone would put true, but all right. So that's good. You're as smart as I thought you were. Next slide, please. Just wanted to make sure we were all on the same page, and don't be embarrassed if you didn't know that. That's why you're here. So we don't use the 2 terms interchangeably. Sex refers to biological attributes such as genes, sex hormones, anatomy, physiology, and immune response, which you're going to hear about more when we get into the methods. And next slide, please. Gender refers to psychosocial constructs, tough word there, we'll get to it, in the lives of women, men, boys, girls, and gender diverse people. And here we're talking about factors like behavior, roles, identities, cultural and societal influences and expectations. And those of you in public health and community health research, I think probably have a better grasp of this as we get into the talk. Next slide, please. Now, this is an infographic that we use a lot in Canada. I invite you to steal it. We're going to talk a little bit about what you could do to teach others. So if anyone wants to borrow this slide and put it in the courses that you teach or use it with your students, I just think it's a great visual showing like sex is really, you know, under the microscope kind of stuff, anatomy, and gender is really our lived experiences. Next slide, please. Now, I need all of you to raise your right hand. Really, I did this at the NIH with like everyone there. Next line, please. And I want you to say, I solemnly swear. Come on. I'm going to assume, I don't see any lips moving. Okay, next, on the scientific method. Next, that I will never again. Next, thanks very much for putting up your hand. Refer to the gender of animals. Next. Until mice are able to communicate their preferred pronouns. So if you are anywhere, you can lower your hand, and somebody says, yeah, I was looking at gender differences in my mice, you're going to go, really? And you're going to correct them and say, I think you probably mean sex because you're referring to biologic factors. So thank you, Jacqueline. You should tell me if I should call you Jacqueline or Jackie, but you would love to use the infographic. I'm happy to share the slides after. You can borrow it from there. Next slide, please. I'm going to answer questions as we go, if that's okay. Next question, true or false? When referring to gender in human research, you should always assume that we're talking about the importance of including non-binary or transgender participants, such as the gender of mice. Is that true or false? I'm not going to continue until somebody writes their answers. Let's see, there's 60 of you looking for 60 answers here. So it's a tougher question, eh? So some people are saying true. Somebody said false. You should always assume that we are talking about the importance of including non-binary or transgender participants. Rosemary, you said false. Well, that's a little lead up to your talk. Next slide, please. The correct answer is false. So why do I say that? Because gender is actually multidimensional. And I'm not saying that you shouldn't think about gender identity, which is the dimension of gender that refers to an inner sense of self as masculine, feminine, both or neither. This is where cisgender, if your current gender identity matches the sex you were assigned at birth, you would say I'm cisgender or transgender. If your current identity does not match the sex you were assigned at birth, or gender nonconforming or non-binary. And yes, it's different than sexual orientation. A good transgender friend of mine told me that, let me see if I could get this right. Sexual orientation is who you want to go to bed with, and sexual and gender identity is who you want to go to bed as. So one's identity and the other one is who you're attracted to. But there's other dimensions of gender. There's gender roles, which are social and environmental expectations that can influence everyday actions such as caregiving or the career you pursue or your role in the family. There's gender relations, which are the interpersonal interactions at family, workplace dynamics, and these vary by time, setting, geography, culture, and religion. I was just on the call before this with the Feminist International Assistance Program and really looking at gender relations in low and middle income countries. Institutionalized gender is the distribution of power in political, educational, social institutions in society. And this, of course, is shaped by social norms and varies by time, setting, geography, culture, and religion. So next slide, when you hear gender, you're going to have to think about which dimension of gender you're actually looking at. So here's the test. Which dimension of gender do these images depict? Please write your answer in the chat. Good, Manali, thank you. Social roles, gender roles, yes, behaviors, yes, exactly. So do you see gender identity written all over here? No, I've just showed you a different dimension of gender that's more the stereotypes, you know, the pink girl, the blue boy, girls are pretty, boys are smart, submissiveness, boys play in the dirt, girls stay clean. These are all stereotypes and expectations that society puts on your sex, which layers gender on top of it. Next slide, please. What about this one? Which dimensions of gender do these images depict? And while you're answering the question, and remember, your choices are gender identity, gender roles, gender relations, or institutionalized gender. Those are your choices. While you're writing your answer, just think that the reason I'm telling you this is because if you're doing research with humans, I'm going to ask you to be very specific about which dimension of gender is relevant to your research, because otherwise you won't be measuring it properly. You know, especially with questionnaire fatigue, you don't want to be asking questions unless it's absolutely going to help you get to an answer that will help the population that you're trying to serve. So good, those are the correct answers. It's actually a little bit of everything. We see gender roles in the caregiving. We see institutionalized gender, you know, the men in suits. We see you know, I don't know if those are nurses or surgeons, but yes, it's all about roles and institutionalized gender here. So next slide, please. Good. So yes, you were pretty good on that one. My second assumption is that you have some idea why sex and gender is important, because I want to get into the methods, but just to make sure that we're on the same page. Next slide, please. True or false? It's safe to assume that conducting single-sex preclinical studies will have no effect down the line on humans. Is that true or false? Where's my basic scientists? I'll let you guys answer this first. Thank you, Sabra. Thank you, Jana. Thank you, Jen. All right, so that was pretty obvious. Thank you, Sarah. Thank you, Manuela. False. Next slide, please. And the reason we know this, of course, is because people died. You know, it's always like, why is this important? Because someone will die. Well, people died. 10 medicines were withdrawn from the market in the US between 1997 and 2000, and you'll recognize some of those names. And it turned out that when we did an audit, we found that 8 of these medicines pose greater health risks for women. Now, do you think it was because of sex or gender that these medications pose greater health risks for women? Write your answer in the chat, please. Was it sex-related factors or gender-related factors? So everyone's writing sex. Ooh, Manali, maybe both. Jen says it depends. I see we have some deep thinkers here. So maybe it's complicated because you might not all recognize the types of medication that were listed. So next slide, please. I'm going to tell you what they were. The answer is that it was gender and sex. So some of those medications were appetite suppressants, right? And who is more likely to take appetite suppressants because of societal's expectations on body image. Not exclusively, but women, especially at that time back in the 1990s, the media, we're getting a little bit better now, really portrayed sort of very skinny women as being the ideal. So institutionalized gender here. And even though the medications did not actually have sex-specific side effects, they caused valvular heart disease equally in men and women. It was only women who were taking them at the time. But some of the medications like Seldane, that was an allergy medication, or Propulsid was for indigestion, they cause fatal arrhythmias in women only because of sex differences in the heart. And many of you know kind of the, when you have a long QT interval, by the way, when you see an electrocardiogram, there's actually letters associated with each peak and trough, and my friends from medicine and nursing know that. And it turns out that women's ST segment is a little bit longer just because repolarization takes longer in female cardiac cells. And so you're more likely to get a fatal arrhythmia called torsade de pointe. And so this time it was a sex-related factor that caused death from these medications. Next slide, please. So both sex and gender play a role. And I just had to put this slide in. This is actually an ad from the Netherlands that says one of the reasons the pharmaceutical system may fail women is because everyone assumes that women are just small men. But even within the women category, look at the heterogeneity and the diversity here that we're going to be coming back to when we talk about intersectionality. Next slide, please. Now, women are twice as likely to report adverse events from medicines than men. And some people will tell you that that's a gender-related factor because reporting is more your ease in which maybe you talk about your health or you feel that you want to report or that you take responsibility. Others might say, next slide, please, that it's due to sex-related factors. And we certainly saw this with COVID, right? You know, right away, we saw that women were more likely to have allergic reactions, anaphylaxis, blood clots. Is that because they were reporting or because there were actually sex-specific mechanisms accounting for the difference in these symptoms? And that, my friends, is what a real sex and gender analysis, when applied properly to research, is going to be able to answer. Now, Sabra, I know you were in the New York Times, it might have even been last week, saying, so is it biology or is it kind of social constructs? This is where the methods are important in order to be able to tease that out. Next slide, please. The sex-related factors, I'm not going to really go through this, but just so you realize it, there's a lot of sex-related factors that can be important. Women's immune system, sometimes they mount twice as many antibodies to vaccines. Sabra's done, a lot of research with the flu vaccine. Sadly, women have more body fat than men, which means that fat-soluble medicines might linger longer. And here I'm thinking of sleeping pills. We talked about women's heart electrophysiology. It turns out that there are 77 genes for medicine metabolizing enzymes or transporters in the liver that are expressed differently due to sex, with or without estrogens, depending on the phase of life that you're in, that I think we're going to talk about soon too. Women's kidneys are just smaller, eliminating medicines from the body at a 15 to 20% slower rate. And women do tend to be smaller than men. Again, this is sex-related, not dimorphic. So the same dose might have a smaller volume of distribution and a greater effect. Next slide, please. Where does this leave us? Well, it leaves us wondering if maybe we should, from right at the beginning of the research pipeline, not assume that one sex will account for how women and men will react in clinical practice. Sadly, though, as you can see in this slide, at the cell and animal level, we're still mostly using male cells and male animals. Next slide, please. Now, why have they been excluded from preclinical research, females? And here's my myth buster. Next slide, please. Of course, people thought, oh yeah, female animals are intrinsically more variable than males due to their estrous cycle, making them generally less suitable for baseline study models. So is that true or is that false? I mean, women do menstruate, animals have estrous cycle. Is this just true? Is sex related? I don't see anyone answering. What do you think? So I do see some falses. Does anyone think it's true? Last time the majority said the opposite. So, okay, interesting. Kind of wish we could have a conversation, but it's really hard on a Zoom kind of workshop-y thing. So next slide, please. The answer is false. 2 recent meta-analyses found that for most applications, female mice and rats are no more variable than males. And you could say, how is that possible, right? Next slide, please. And it turns out that a lot of the variability came from the group housing. So although the estrous cycle may account for some variability, it turns out, for those of you who don't work with animals, that you actually separate male and female animals, because if you let them live in the same cage, that could really add confounders to your experiment. Let me just put it like that. But when males are in group housing, that whole alpha male kind of group dynamic comes out, maybe testosterone levels start, going up and down. And so the absolute variability in characteristics is actually the same between males and females. So myth buster right there for all of you for the next 10 years who speak to a basic scientist who tells you, oh no, I could only do it with male animals. You say, oh no, you have to find a way to also study female animals. And it's not that they are going to be more variable and mess up your experiment. Next slide, please. So, we really do need to tailor our approach from a one-size-fits-all in science and research towards one that's more personalized towards sex and gender. Next slide. And the good news is that great things happen when we do. Here, just to show you, the FDA actually lowered the recommended dosage for women and older adults taking sleeping medication, because based on what I told you about all those different factors that make medicine linger longer in the body, it turned out that the peak blood concentration of a sleeping pill Ambien was 45% higher in women than men 8 hours after taking the medication. So, I shouldn't say this. Are we recording this? Definitely shouldn't say this. As I tell my husband, it's not that women are worse drivers. It's just that maybe they have more sleeping pill medication in their blood first thing in the morning, which detracts from concentration. And it's just interesting that, they're already color coding the boxes and everything. But is that the way of the future? Will there not only be different doses, but completely different medications for men and women down the line? And that, I think, is one of the promises of sex and gender-based medicine. Next slide, please. In terms of the gender part, well, when you do start thinking about here, what aspect of gender is this? This would be gender identity for trans individuals. Well, cancer care could be different. And a lot of healthcare providers don't know that the words we use, the approaches, top surgeries, bottom surgeries, being a trans man, but still being at risk for breast cancer. These are things that you really have to start considering if we're going to be inclusive of gender identity. Next slide, please. And outcomes improve. So that was my intro. Let's jump into the methods. In Canada, we call sex and gender science sex and gender-based analysis. Here's my 101. Next slide, please. The first thing that you need to do is consider each stage of the research process separately. So from research question to research design to knowledge mobilization, and have a checklist for yourself about how you're going to address sex and gender at every stage of the research process. Next slide, please. It's not a one-size-fits-all. There are going to be some general principles. And then the reason I asked you about your field is because there's going to be specialized approaches depending on, for instance, if you're collecting, primary data from a sample, or if someone gives you a data set and the variables are already there and you have to figure out how to manage the sex and gender related variables. Next slide, please. But the first step, no matter what field you're in or what stage of the research process you're in, is always going to be the same. What is it? What is the absolute first step in a sex and gender-based analysis? And here I'll let all those of you who said that your confidence was at a 7 or higher level take a stab and write in the chat, what is always the first thing that you are going to do? There's no wrong answers. Can't go on with the talk until somebody says something. Disaggregating data by sex. defining your terms. Very good answers. Anything else? Counting how many people you have. If it's a human study, disaggregate data by sex, or figure out if it's self-reported sex or if it's self-reported gender, disaggregating. Okay, you guys are good, but I'm glad that I could teach you something. Next slide, please. The very first step is your literature review, okay? Because you don't know what you don't know. And sometimes I give talks, you know, on microbiome or on cystic fibrosis or on all kinds of things. And I see my audience going, nah, it's really not relevant to my field of study. And then while I'm talking, I say, go do a Google search, because you may be missing out on the next Nobel Prize, because if nobody's discovered anything, you might actually discover something groundbreaking. And by the end of my talk, no one's listened to the rest of it. They've all done their Google searches and then, or PubMed searches or whatever it is. And they come up and they go, wow, I just found a review paper. I didn't even know that people have looked at this and there are differences. So start with a literature review about sex and gender differences, whether it's the incidence of the disease that you're looking at, the manifestations, the mechanisms. I personally love mechanisms. I'm going to talk to you about the progression, response to treatment, interactions. How does gender affect, I don't know, sexual and reproductive health, or, you know, so you can look up general methods and read review papers, but also really look in your specific area. If you want, go do your PubMed search right now. You don't need to listen to the rest of my talk. If you do that, then I am sure that you'll have learned something today. And if one doesn't already exist, Sabra says she'll help you write the review. Okay, next slide, please. So second step, some of you wrote this, is define your terms. So define your terms, but even more importantly, determine which dimension of sex or gender is relevant to your research. So don't just tell me sex is relevant to my research. Are you talking about the hormones? Are you talking about genes? Are you talking about the reproductive organs or the chromosomal complement? Like, which aspect of sex do you think is going to be most important? And like we just said, don't tell me, oh, of course, gender is important. Is gender identity and gender roles and gender relations and institutionalized gender important? One or none of the above. And then, of course, I'd be remiss in saying that we need to consider other identity factors. So is this an area where racism has created bias? Is this an area where ageism has created bias? Is this an area where sexual orientation or socioeconomic status is important in the causal hypothesis to explain cause and effect, which is really, you know, at the heart of the scientific method? Next slide, please. So make a list. And here's my tip. If your study doesn't involve humans, gender and other intersectional factors are likely not relevant, except for age and strain and all that stuff if you're working with animals. But I was talking more about identity factors there. Next slide, please. So now that you have maybe figured out that you want to measure sex and gender identity, let's say that you're doing primary data collection. In Canada, we could recommend a two-step question. Now, there's different ways of doing it, but of course, you need to ask what sex you were assigned at birth, or which currently describes your gender identity. In Canada, we work and respect Indigenous identities, as well as adding racial ethnic questions to our questionnaire. So we ask about Two-Spirit, which is an Indigenous gender identity. But again, because in a lot of data sets, you might say, what is your sex? But people are reporting their gender, or you might have gender when really it's a clinical study and they've been measuring sex. And so right away, you kind of have some misclassification bias. So if you have the opportunity to ask questions, it's best to be specific in your measurement in primary data collection. Next slide, please. Now, for measuring gender, here again, the gender-related variables that may be relevant, it's not enough to say, oh, I'm interested in gender roles. Which gender roles are going to be important to your research question? Is it your household work, your childcare responsibility? Are you the primary breadwinner? If you're trying to measure kind of a gender role index, there are constructs, and I would refer you to Louise Pilot's work for measuring, doing a factor analysis and figuring out the different contribution of gender roles. Same, how do you measure gender relations? Is somebody married? Is there spousal support? What's the relationship with others? There's a gender equity index for some countries, gender equality index that you could use. And in terms of institutionalized gender, it might be helpful to look at the status of women in a country or community, or the educational attainment level, or average personal income. So there are ways from a variable point of view to capture these constructs. Next slide, please. So step 3, this is where I think many of you were saying counting the numbers or including individuals. Make sure that you include males, females, and intersex individuals if appropriate when studying models of disease that affect all sexes. Next slide, please. Step 4 is consider your sample size and analysis approach. Theoretically, we'd love to have sufficient sample size to be statistically powered to allow for sex and gender specific subgroup analyses. I think, Sabra, you're going to be addressing this a little bit more, but my point here is that if you do have sufficient sample size, that's great. You could look at effect modification and interaction. You could probably detect main effects within sex strata, but even if you have low statistical power, even if you only have 10 participants, disaggregate by sex, just from an exploratory look at the raw data point of view. There may be huge differences, and that's important. Some people say don't do your subgroup analysis because it heightens the risk of type 2 error or false negatives, but you don't always have to apply statistics. Remember the beauty of just looking at your raw data, and I'll show you an example. Next slide, please. So if you are stratifying by sex, even if you have few numbers, for instance, some people say, oh, but I don't have a lot of transgender individuals in my study. At least report the raw data in the table, even if you don't analyze it, so that a future meta-analysis can take into consideration those individuals. Next slide, please. And the consequences, here's the scatter plot I was talking to you about. When you're pooling your data, even if I don't have sufficient sample size here, just disaggregating it and plotting it out, even with a low sample size, if there is a huge effect, and here you see that there's a huge effect by sex, it's going to be obvious, and that'll give you the preliminary data to apply for more money to do a more mechanistic type, why is there this difference kind of study. Next slide, please. So Rosemary, I think you're going to go into detail. This is a paper by Rosemary and Sabra, actually, where they go into detail about the way of doing this. So I'm going to leave that as a teaser in the interest of time. Next slide, please. But one thing I don't want to ever see is, we control, well, I'll test you on that later. Okay, so then step 5. 5 is 5A and 5B. And step 5 is my favorite part of the entire sex and gender-based analysis. And that's about the why. So science is about mechanisms. It's about the causal pathways. It's great if you find a sex difference, or great if you account for sex and gender, but I really want to know why you're doing it and what do you find. So let's say that you do disaggregate by sex and you don't find a difference. Then explain that you disaggregated, you didn't find a difference. And I remember a study, I didn't put it in my slides, on depression. And they found that the depressive phenotype, meaning the expression of depression, was the same in male and female animals, but there was a totally different molecular pathway. So could your, antidepressants for men and women actually end up being different based on the way the brains work, even though we all experience depression? And then look at the source of the sex difference. So explain the underlying mechanism. You want your Nature paper? You're gonna need to explain the mechanism. Next slide, please. Now, could a sex difference, I talked a little bit about animal research, but could a sex difference be explained by a gender-related variable? And this, I love speaking to epidemiologists and statisticians who go, well, where's the gender variable? And we talked a little bit about this. In your analysis, are you going to have to draw on proxy or associative variables for gender? There are ways of constructing a gender story with the variables that you have in the narrative to explaining your findings. Next slide, please. And then to give you an example, in this study, comparison of hospital mortality and readmission rates for Medicare patients treated by male versus female physicians, the data was collected by biological sex. Now, should they have actually said men and women? Probably, but is it still possible that the results may be explained by gender? It turns out that it was a gender relations phenomenon. It turns out that when there was a woman physician working with men, the entire team was more likely to ask about women's health conditions than if there were no women. So that's really gender relations, because where you sit is where you stand, and the perspective that you bring from your lived experience, whether you like it or not, is definitely going to affect the objectivity or subjectivity with which you view your work. Next slide, please. Now, step 5B, I talked about a sex-based analysis. Is gender-based analysis is the same thing. You're going to want to take your gender variable, and you're going to want to look at different dimensions of gender. If you find a gender difference, you want to determine the sources of gender difference. And here I've listed different sources, and we won't go into too much detail because that's more in the follow-up talks. But report the underlying mechanisms. And is there gender bias? We're going to talk a little bit about gender bias and how would you mitigate solutions to that, and why does it exist? And you're going to need to know the why so that you could get rid of the gender bias if it leads to worse outcomes. Next slide, please. And finally, for those of you who are not familiar, do you want to write yes in the chat? Who's heard of the gender responsive assessment scale? This is one of my favorite scales for public health. It divides public health implementation interventions, especially in low and middle income countries, according to whether they're gender unequal, which you could read perpetuates gender inequality and exploits gender, all the way to gender transformative interventions, which includes ways to transform harmful gender roles and relations. So this is a guiding principle, even not in low and middle income countries, even when you're talking about smoking and pregnancy. Is it the woman's role not to smoke because the pregnant person might harm the baby? Or is it the environment, and within the couple, should this be a family approach to healthy children where no one allows secondhand smoke to get in? So that's gender transformative in the way that you deliver your message. Next slide, please. All right, so those of you in public health, write true or false. The concept of a personal or SGBA, sex and gender-based analysis approach, is in direct conflict with the ethos of a public health approach. Do you think that's true or false? Right? Because how could you be considering the individual if public health is about the greater good? So I'm getting a few falses. Where's my public health people though? You can tell me it's true. All right, next slide, please. To show you that it's not in conflict, I'm going to tell you a super cool public health story on what happened when they looked at sex and gender. Next slide, please. And this story happened in Sweden when they looked at snow clearing. Do you guys have snow in Baltimore right now? We have about 3 feet outside my window right now. Okay, so next slide, please. So really relevant to my life. And Ottawa, Canada's capital city, a few years ago when we got a lot of snow, said, should we adopt Sweden's gender balanced snow cleaning policy? Now, why would you have a gender balanced snow clearing policy, right? This is just how cool sex and gender analysis can be. Next slide, please. Here's what happened. In Sweden, they kind of said, we really want to be thinking about healthy cities. And we've noticed that we have a lot of pedestrian injuries. And somebody said, okay, let's do a sex and gender-based analysis. Are there sex differences in our pedestrian injuries? If yes, let's try to figure out why and figure out if gender plays a role. And if no, are they the same type of injuries for men and women? So next slide, please. What do you think they found? Well, here's what they found. They said, are there sex differences in the type of pedestrian pedestrian injuries that we see. And it turns out that 69% of single person injuries involved women, and that 79% of these injuries happened in the winter. And then when they looked at the mechanism, remember I talked to you about mechanisms? 2/3 of these women had slipped or fallen on snowy or icy surfaces. And I don't need to tell you that, women live longer than men. A hip fracture is the worst thing that could happen because 1/3 of them, after surgery, don't recover their function. About 10% go to nursing homes. I mean, you want to avoid hip fractures, right? Next slide, please. So that's kind of interesting. And then they had this really smart analysis team, and they said, so should we just stop there, or does gender play a role? Why is this happening? And it turned out that the first streets to be snow cleaned were the large arteries leading into the downtown financial big business sectors of the city, and that smaller streets and sidewalks and bike paths were cleared afterwards. Now, this might not be exciting to you, but here in Canada, we have a lot of snow, and this just really, really resonates, as it probably did in Sweden. Next slide, please. So, older women, women with unpaid work, and women with lower socioeconomic status were more likely not to use cars and take those small uncleared paths. Next slide, please, which led to more injuries. Then somebody said, well, the cost of pedestrian injuries, when you consider that hospitalization and nursing home admission rate, is actually 3 times higher than the cost of snow clearing. So, next slide, please. Why don't we switch it around and clear the sidewalks, the bike paths, and the small streets first, then clear the roads to hospitals and schools where more women are going, and last clear the snow from the large arteries? What do you think people were happy about that? Not at first, and the first 2 days was a bit of a disaster. Next slide, please. But in terms of public health outcomes, there was a 2-fold decrease in pedestrian accidents. And here's what the local counselor in Stockholm's traffic department said. So thank you, Jackie, for putting that gender women wear shoes, boots that are more slippery. Very interesting. I'm going to put that into my next talk. Next slide, please. Although I'd have to, do a study there. So how might you apply sex and gender-based analysis in medicine or nursing? Because I haven't talked a lot about that. Next slide, please. Well, I'll just give you a little trigger to go read Alison McGregor's paper, which is my favorite on this topic, because she talks about 6 cognitive steps to integrate sex and gender into clinical practice. You're going to want to identify your patient's sex and gender, what someone looks like and how they express sitting in front of you. Biologically, maybe they were born with a uterus, even if they look like a man. So ask what their gender identity is, what pronouns, and that'll give you an idea. Understand sex differences and clinical manifestations of disease. You know that fatigue is more common in heart attack symptoms in women instead of that crushing chest pain or arm pain that men get. Recognize potential limitations in diagnostic testing. I showed you that EKG. Women's EKG is a little bit different. And our biomarkers, even our biomarkers for measuring heart attacks, have different thresholds for what's sensitive or not in women or men. When available, dose medications based upon sex-specific evidence, and mitigate gender bias. Next slide, please. So here might be an example of gender bias. What do you think? Women are diagnosed with depression twice as often as men. Is that true, or is there bias there? Tell me if you think there's bias. Next slide, please. You're right, Rosemary, there is bias because men account for 3 out of 4 completed suicides. So you're not going to tell me that they're not depressed. So is it in the way the questions are phrased? Do you feel sad? Do you cry a lot? Because of societal expectations and gender norms, men probably won't come forward with those symptoms. So gender bias is killing people in our healthcare system. Next slide, please. All right. So I think I have 2 more minutes. I just that was my 101, maybe a few pointers for my 201. Next slide, please. Sex can come in many different shapes and sizes, right? I don't want anyone thinking about sex as binary. Next slide, please. And here I'm not just talking about intersex, I'm even talking about hormones. So would you call testosterone the male hormone and estrogen the female hormone? Next slide, please. The answer is no. Next slide. And I think, Sabra, you might go into this, and I think you might even have this slide, that at all phases of your life, males and females, here I'll say males and females, because I'm talking about biological sex, will have varying levels of testosterone and estrogen. So estrogen is not a female hormone and testosterone is not a male hormone. Next slide, please, which really makes you wonder how we get into situations like the female eligibility criteria for Olympic sports, where these women were told that if their testosterone levels were above 5, a certain level, then they couldn't compete in female sports. So now is being a woman defined by the male hormone level? So this is where I think our thinking has to evolve when we talk about sex and gender science. Next slide, please. Sex exists on a spectrum. You know, a lot of people born with XXO, XXY, right? Just like gender exists on a spectrum. So I want people to move towards spectrum thinking if they've mastered the 101 level. Next slide, please. And I also want you to, as in some of the examples, realize that you can't always tease it apart, right? Like, I don't know why more males are dying in some states because of COVID, but at other points of time, it's women. And there's a lot of hypotheses. And again, go read Sabra's article in the New York Times last week, but sometimes you just can't pull all this apart. Next slide, please. And what I also want you to realize is that you can't say, oh, it's too complicated. You can actually work through sex and gender analysis. So asthma is more common in males before puberty, but more common in females after puberty. Is it because of sex differences and lung development and hormone levels and immune responses to allergens? Or can it be because of gender, because boys are playing in the dirt and maybe they're more exposed to different microbes or differences in smoking habits? Or do women who are pregnant just not want to take their inhalers, their corticosteroid inhalers, because they're worried about the effects on the baby? Well, then gender could influence our biology, because when boys play outdoors and they're exposed in the dirt and they're exposed to different microbes, then this can in turn influence epigenetic processes, which in turn could modify gene expression. So important to think about the whole picture. Next slide, please. Language is important. I've tried to be specific about usage of the words male, female when I'm referring to biology. Don't talk about, male chromosomes, talk about the Y chromosome. I think that we need to be inclusive in the science that we do, and that's just part of respectful, inclusive scientific excellence. So just want to make a point there. Next slide, please. And this again is at the 201 level. Then if you want to go to the 301 level, you could throw in the plus for sex and gender-based analysis, plus, and start considering other intersecting identity factors if you're working with humans. Next slide, please. And here I would really refer to, situating yourself and others. Intersectionality is about positions of power and privilege and how people self-identify along different social lines. And here I just kind of like, you see one person, but look at all the factors that make up their identities. Next slide, please. And that could influence their health and their interactions. And I'd be remiss in using the word intersectionality without giving credit to Kimberly Crenshaw, a Black feminist legal scholar, who says that it's really a lens where you see where power comes and collides. It's not simply that there's a race problem here, a gender problem here, and a class or LGBTQ problem there, but there's an intersection, next slide, that leads to the experience being more than the sum of each one individually. And that's actually how you do an intersectional analysis. So again, for those of you who teach, I like this wheel of power and privilege because it kind of shows where the intersections can collide in the power or marginalized part of the spectrum. Next slide, please. And I like to think of racism along the same lines as I think of sex and gender, very different historical context, but biological. It's important what your genetic ancestry is, but that has nothing to do with your race and racism, which are social constructs, and how you might account for that when you try to measure these as variables in your research to mitigate some of the negative effects. Next slide, please. And like I said, what makes an analysis intersectional isn't just trying to measure each characteristic separately, but to really look at individuals who have intersecting experiences of power and privilege. So how do you know how to do that? In your research question, you need to say, who am I most interested in? Next slide, and I think I'm wrapping it up here, just so you can ensure that sex and gender science benefits everyone. Next slide, please. A little shout out that in Canada, we actually ask people, and you should be doing this too, you know, how is sex accounted for? How is gender accounted for? Next slide. It's not just for them to say yes, it's about the quality of their response. Next slide. And so you're going to have to assess if it's weak or strong. If someone writes, we'll adjust for sex and gender in our analyses, do you think that's weak or strong integration? What do you think? Write in the chat. Weak. Thank you. Next slide, please. But then if you say, how do you account for sex or gender? And they say, okay, I'm going to look at it in the research design and the methods, and here's how I'm going to do it at every single stage. And they actually list out all the stages and they say how it's going to be considered. Is that weak or strong? That is strong. So you need to be the quality control person. Next slide, please. And if you want to, you know, I'll skip this slide, but they're just more examples that even when you're looking at a single gender or a single sex, you could still account for sex and gender. Here's the link to our training modules if you want to learn more. Next slide. We also have what we call a Meet the Methods series, where it goes into the details, and I might have some of you do some on this call. Next slide, please. And, you know, if you're a student, pay attention and point out in class if they're not accounting for sex and gender in lectures, assignments, or clinical cases. If you're a researcher, call out your peers during research presentations. If you're a teacher, make sure it's integrated in your course curriculum. If you're a clinician, pay attention to inclusive language during clinical care, as well as the cognitive steps. Next slide. If you're reviewing for a journal, then make sure that it's accounted for. Sabra, I know you're very good at this. If you're an epidemiologist, ask about gender bias in the data collection or misclassification. Ask questions during a thesis defense or conferences if data on sex and gender aren't taken into account, or maybe start a working group like you're doing at JHU, a community of practice for sex and gender-based analysis. Next slide. And that's it. There's publishing guidelines. Next slide, and I think over to you. Some people put questions in the chat. I invite you to be bold and push boundaries, be the leaders others will follow, because one day the world will thank you. So there were a few questions as we went along, like where you could get my slides, and I'm happy to share those. Are there any other questions before we dig into the methods? We have 3 amazing presentations that are going to go deeper. So maybe you could put your questions on the methods, but maybe Sabra, I'll turn it over to you to dig into them. Wendy's asking, regarding publishing, how do you think biomedical journals and their peer reviewers are handling manuscripts that account for intersectional effects, like when researchers discuss how their lived experience might have impacted their analytic approach in reporting? Well, I think that's a great practice to report how lived experiences might have impacted your analytic approach in your reporting. I would say that, like any theory of innovation and any change theory, there will be currently 25% of biomedical journals who say fabulous, that's in line with our policies. I don't know if it's Nature or JAMA, but there are a few, no, Cell has a statement about this. So there are certainly some leaders in the field, but there are going to be many who are going to say, why are you telling me this? This isn't important. I never had to do this. It worked for me. Why does it work for you? So we're going to have to change hearts and minds, but that's why you need to be the leaders that others follow. It may not be easy, but one day the world will. Thank you. Sabra, did you get any questions? I don't have any other questions. Oh, maybe from Michelle. I appreciated your point about publishing similarities, findings, and sex gender analyses. Exactly. The emphasis on differences perpetuates an emphasis on binaries and the idea that men are from Mars, women are from Venus. Thank you, Michelle. That's true. Some people don't even like the term sex differences analyses. And you'll notice for the most part, that's why I talked about a sex and gender-based analysis. And I also talked about accounting for sex and gender, or factoring in sex and gender. And at least, although sometimes sex differences are important, I don't have that as the only way to incorporate sex and gender into your research. So thanks for pointing that out. Over to you, Sabra.
Oh, thank you, Cara. Anyone other questions? Anyone want to unmute themselves or ask anything before we move on? Okay, well, I'm going to encourage you to continue to put questions, including for Cara. I think, I know I learned a lot, and thank you, and just continue to ask these questions. And so, as I noted in my introduction, I'm joining you from a basic science department. And what I thought I could do is talk a little bit about the basic science. I recognize that many of us in this webinar are joining from nursing and from the School of Public Health and from medicine, doing clinical and more public-facing research. But a lot of times we do want to pair up with people like me who are also working in basic science models for more of that translational, that mechanistic insight, where we can explore some of the mechanisms of sex and how to consider, as Janine Clayton termed it, and she is the director of the Office of Research on Women's Health at the NIH here in the United States, sex is a biological variable. So next slide. So it was in 2016 that the NIH, it was announced that the NIH was going to require consideration of sex as a biological variable in grant applications. So I guess following Cara's lead, do you think, is considering sex as a biological variable, does that mean we all have to study sex differences? Anyone want to write in the chat? Do you have to study sex differences? No, thank you. No, it just means, much as Cara pointed out to us, it's going into the literature. It's knowing what's in the literature. It's considering whether there is any evidence of a biological difference between the sexes, and allowing that to factor into research design, analyses, and reporting, both in vertebrate animal and in human studies. But the policy does not require that you use specific methods, that it's not requiring that the beautiful intersectional analyses that Cara is encouraging us to do, which we should be doing. But the NIH policy is not requiring that we do that, or double sample sizes or power studies to detect sex differences. But by considering it, you might do some of those exploratory analyses, or those exploratory ways of graphing or presenting data, as Cara showed us, where you're disaggregating. So maybe you don't have the power to statistically compare males and females, but you might be able to show trends. You might even be able to include, even if you have a very small proportion of individuals who are intersex, because just as Cara described to us, sex is occurring on a continuum. Even though you may have a very small percentage of individuals who fit into that category, to just be able to pull them out to see where their data are falling on some of our outcome measures could be very meaningful for future researchers. So considering sex as a biological variable and studying sex differences are not the same thing. It's really about balancing your experimental design and including both males and females, as well as intersex individuals, if this is a human study, into your experimental design. Next slide. But what I think is really interesting is that there are a number of examples where it turns out that by not considering sex as a biological variable, especially in our animal studies, and I think Cara did such a beautiful job addressing that, other than for housing conditions and a few other factors, we really do not assign gender identity, or some of those more gender associated factors in our animal studies. So disaggregating and having this binary, if you will, of males and females, I think is a little, it's just, we can have that type of distinction. And so what I'm showing you here is some data from Louise McCullough, who actually did her residency here at the School of Medicine at Johns Hopkins. And so while she was here, she was doing some animal studies. She's a clinical scientist, and she was testing treatments for stroke. And what she put forth was that she included both males and females. And if she aggregated her data, if she just combined both males and females and looked at the impact of this drug treatment on her stroke outcomes in her mouse model, she had no effect of her treatment. But if she disaggregated her data and separated out the data based on whether these mice were males or whether these mice were females, there was a very interesting interaction and a sex difference that was observed, in which the treatment significantly reduced stroke outcomes in males, but it significantly increased stroke outcomes in females. So suggesting that the mechanism of repair following stroke may be very different for females than for males. And much like what was being discussed about the drugs that have been withdrawn and the lack of this type of consideration that goes on in preclinical research, it leads to these type 2 errors where either you think a drug isn't working at all, or unfortunately, when a majority of preclinical research uses only males, we might think that a drug treatment is going to be equally effective and equally safe for all individuals. So data hiding in plain sight, I think, is such an important concept for why sex as a biological variable needs to be considered in preclinical research. Next slide. So how's your field doing? I just have a few disciplines. I realize this isn't everything, and this does not really highlight public health and public health relevant research, though it does hit on a little bit with regard to behavior and reproduction and even behavioral physiology. But what was interesting, so Teresa Woodruff, who leads the Center for Women's Health at Northwestern University, they looked at published studies and the proportion of articles that were either reporting only using male animals, only using female animals, reporting using both, or not specifying. And they compared what data looked like in top journals in different disciplines in 2009, so prior to the introduction of this policy by NIH, and then after introduction of this policy in the United States. And so what I do think is encouraging, purple means using both sexes. What you can see is that there is an increase in the proportion of studies reporting using both sex in diverse disciplines. And you're starting to see a reduction in that gray area, those studies that are not even bothering to specify, those studies that are just saying mice were used. Much like what Cara pointed out, I mean, if you look at pharmacology, you can see all that blue, the over-reliance of only male animals in certain fields, and how much this needs to change. Next slide. And can you do it again? So, you know, a point I want to make with you is that we can all think about how well our fields are doing. I really didn't see my field being represented. And when I looked at following of those Sager guidelines that Cara pointed out to us, I realized in my field of microbiology and immunology, nobody even knew what those guidelines were, let alone were they using it. So I went to the editors in chief of some of the basic science primary research journals at the American Society for Microbiology, one of my societies, and they have a family of journals. And I said, I'm surprised that nobody requires this. And I showed them data. So I think sometimes you got to show data. And so I showed them for MBio, infection and immunity, and you can see all of the different journals that are basic science journals that publish primary research papers. And if we just take Journal of Virology, I work with viruses, as Cara pointed out, and that's a journal I go to. And so when we looked at 930 journals, journal articles that had either primary cell culture or animal, and those were just designated as the white and the yellow. And then you can go down, we can look at the animal studies. So for Journal of Virology in 2016, so a year after the introduction of SABV, you can see a lot of Black, a majority of papers, at least 50% were not mentioning the sex. Here we had a little bit more of a bias of female animals. And the reasons I'm often told is that they're not as mean, they don't bite, they're easier to work with. And these are literally things I have heard when I have questioned my colleagues in conferences. But then if you look at the primary cell culture studies, and again, let's just stick with Journal of Virology. Again, it's even more appalling. In primary cell culture studies, meaning cells have been taken directly from animals or directly from people, and they've been put in a plate, and now they are often considered to not have a sex. And I'm going to show you that they have a sex. 80% of studies in primary cell culture don't bother to mention the sex. And these are the kinds of things in basic science that need to change. And I will tell you, as a result of this, for the American Society for Microbiology, they now have requirements about sex reporting at their journals. Next slide. So Cara mentioned, what can cause sex differences? Well, when we're talking about these preclinical types of studies, we're talking about sex chromosome genes and we're talking about hormones. Sex chromosome genes refer to our sex chromosome complement, which for a majority of us is going to be either XX or XY. Absolutely, there can be disorders of sexual development that result in differences and anomalies that absolutely can occur in sex chromosome complement. We can also have in intersex changes and differences that occur that result in individuals who have both gonadal tissues indicative of both male and female. But for a majority of individuals, and definitely when we're talking about animals, this binary really does apply. So on the X chromosome, we're going to inherit the X chromosome, we meaning females, can inherit the X chromosome from both the maternal as well as the paternal. And together, there can be random X inactivation of genes on the X chromosome, such that a female really reflects a mosaic of gene expression of this random X inactivation of either the maternal or the paternal copy. So you get a lot more genetic diversity in females as compared with males. Our sex chromosome complement can play a role, so there can be a bit of a dosage effect. It turns out that in humans, roughly 15% of genes can escape X inactivation and be overexpressed in females as compared with males. In males, on the Y chromosome is a gene called the SRY gene, which encodes for testis determining factor, which is one of the factors, it's the primary driving factor causing a bipotential gonad to develop into a testis, as pictured here, that will secrete high concentrations of testosterone, initially prenatally, to lead to some masculinization of tissues, including the brain. Can also lead to epigenetic programming of male cells. So we can have in utero effects that can occur, these genetic effects, and that these can contribute and be the how do sex differences arise. Next slide. The other how is our sex hormones. And as Cara beautifully pointed out, there are no such thing as male sex hormones and female sex hormones. The difference is in the ratio, and those ratios can change over the life course. With estrogens and even progesterone, not pictured here in this cartoon graphic, typically occurring in higher concentrations in biological females as compared with males, whereas testosterone is typically found in higher concentrations in biological males as compared with females. Again, a modification that needs to be made with calling these men and women now that we all fully understand distinctions between sex and gender. But a point that I do want to make, and that I do like with this particular cartoon graphic, is that the other thing that we need to be thinking about is that our hormonal milieu is changing over our life course. It's going to peak in adulthood and then decline precipitously in females during that menopausal transition. You're going to see a decline that occurs in males as well. It's not as steep of a decline, but it is a more gradual decline that can occur with age. And so I think one important point as we move forward, we need to ask ourselves whether our animal models actually reflect the age and hormonal status of the population we're modeling. Next slide. So I just superimposed this onto what we know about aging in mice. Okay, so majority of us who do translational animal models, oftentimes we see that people work with mice and report the ages of their mice in their papers. Maybe they report that they were 6 to 8 weeks of age. 6 weeks, roughly, the animals have just gone through puberty, but I think we really need to start asking ourselves what it is that we're modeling. If we go back to Cara's discussion and with us about depression, we do find that a majority of the patients being diagnosed with depression are middle-aged females. Sex and gender and the intersection absolutely plays an important role, but when you look at who is taking a majority of the medications prescribed for depression, it is middle-aged women. Yet a majority of the preclinical studies of depression are conducted in young adult male animals. Again, no real clear distinction. Next slide. We have animal models that we can use to interrogate sex differences. We can study hormonal effects by surgically removing the gonads, removing the testes in males and the ovaries in females. We can give back hormones exogenously in different concentrations, in different combinations. We can even reverse. We can take out the gonads of females and give them higher concentrations of androgens. We can take out the gonads of females and give them higher of males and give them higher concentrations of estrogen. We can study the natural loss of sex hormones, which do occur in animal studies. We can study sex chromosomal effects. One mouse model that we have here at Johns Hopkins and that I work with my students are the 4-core genotype mice, which allow us to separate sex chromosome complement from gonadal sex, because the SRY gene that I mentioned previously has been deleted from the Y chromosome, inserted into the autosome, where it can be inherited autosomally in individuals with 2 X chromosomes. So you can end up with XX individuals who have testes, as well as XY individuals who have ovaries, and study the individual as well as the combined contribution of sex chromosomes and sex hormones. There are also consomic Y chromosome mice who allow us to study differential genes associated with the Y chromosome against different backgrounds, which has proven to be very integral for understanding regulatory elements on Y chromosomes associated with autoimmune diseases. Next slide. You can uncover the sex of your cell lines. I'm going to not spend a lot of time on this, and only to say that there are definitely papers out there that have researched this. And we do know that these cell lines are often genetically more ambiguous when it comes to sex chromosome because they've been immortalized, but there can be a reason to at least know the sex of your cell lines. Next slide. And the last point that I want to make, and I'll just go ahead and have you do the next slide again, is consideration of both sex and sex hormones in primary cell culture. We often take for granted that there are estrogenic compounds in all the media that we use for growing our cells. Fetal bovine serum, fetal calf serum are estrogenic, as well as phenol red, which is often used as just telling us about the nutritional status of our cell cultures, but these are estrogenic and play a role in differentiation of cells that we take for granted. We know a lot, and we've even heard a lot about viruses like SARS-CoV-2, but also even HIV, hepatitis C, and even Ebola, that estrogens can be antiviral, when my group and others have now shown that the only way that estrogens are actually antiviral really depends on the sex of a cell culture, whether in this case the primary cells came from females or from males. And my last slide. The last point that I want to make, and I bring your attention to a wonderful review with statistical considerations of sex differences versus sex-specific effects in exploring what it is that we're studying. And so when we have our animal studies or even our cell culture studies, and we've got females and males, we have in our treatment and our control, both Cara and myself have given you examples of looking at the interaction between sex and a treatment as indicated in panel B, but sometimes the differences are not that profound or are not that clear to tell us that there is an actual sex difference. So what's being shown in panel C is that there can also be sex-specific effects in which a treatment only works in one sex but not the other, something that I think, rather than giving it a big red X, is something with which to explore as well. And so I will end with just a few take-home messages. Considering SABV does not mean that you have to study sex differences. I think this is important for reproducibility and rigor. We need to know the sex of our cells as well as our animals and be reporting that in our publications. Sex differences can occur in both primary cells and animals. And what's wonderful about our preclinical models is that we can manipulate both the sex chromosome complement as well as the hormones. And I think it's really important statistically to understand the difference between a sex difference and a sex-specific effect. And some resources that I've listed here from both NIH and the Canadian Institute of Health Research. Thank you. I'll welcome Rosemary.
Thanks, sir. Thanks very much, Sabra. So for those that may not know me, I'm Rosemary Morgan. I'm an associate scientist based in the Department for International Health at the School of Public Health. And I would classify myself as a social scientist and a qualitative researcher. And many of you, like me, might not have understood very much of what Sabra said. So, and that's okay, because sometimes biological sex differences, we don't study that in public health, and today I'm going to be focusing specifically on gender differences and looking at gender analysis. Next slide, please. So just a quick definition when we're talking about, gender analysis and what is gender analysis. So here it is defined as the process of analyzing the ways in which gender power relations and their intersection with other social stratifiers manifest as inequities to affect people's lives, create differences in needs and experiences, and how our policies, our services, and our programs can help to address these differences. You heard Cara talk about gender roles and relations, and you heard her talk about intersectionality, and a lot of that is encompassed in this definition. Next slide, please. So I'm not going to go into too much detail into this diagram, but what I wanted to show you on the right is the gender assessment scale that Cara presented from the World Health Organization. You can see you've got gender unequal, gender blind, gender sensitive, gender specific, and gender transformative. And what we've done is have looked at specific tasks that that researchers and implementers can do and that's what you see the blocks on the left in the pyramid, to do gender sensitive programming or specific or transformative. Next, please. today I'm going to focus on just 3 of these. So there's a lot more that we can do to integrate a gender lens. And I'm going to be focusing on the base of the pyramid, on the foundation, because everything at the bottom of that of this pyramid is relevant for gender sensitive, specific, and transformative. So we're going to look at disaggregated data, using gender analysis frameworks, and thinking about gender analysis questions in our tools. Next. So a quick note about gender identity versus gender power relations. Next. So Cara made this distinction already. And I think this distinction is really important because often when you hear that, let's talk about gender, let's study gender, a lot of people go first or think about actually gender identity, right? Thinking as opposed to gender power relations. Cara made the distinction very beautifully, so I'm not going to go into too much detail. But what's important is how we ask about each and how we collect data about each is different. So our socio-demographic questions ask about gender identity. So when we're talking about sex or gender disaggregated data, we're actually talking about gender identity, disaggregating data by a person's gender identity. Often, we all very much see gender identity being conflated with sex, and it's assumed that their gender identity and biological sex may match. That's maybe in our questioning, we're not asking the right questions. And as I've mentioned, gender identity facilitates disaggregated analysis to explore where inequities exist, but doesn't really help us to explain why those inequities might exist. And that's where gender power relations and gender analysis comes in. And it is more complex to incorporate this lens in your research. So I'm going to be talking mostly today about how we can integrate or think about gender power relations in our research. Next slide. Here's quickly a slide about asking about gender identity. Cara gave examples that you can see are slightly different than what's here. What's here, I've got questions that go from less inclusive to most inclusive. And this is important because while the gold standard and why we should all be striving to be as inclusive as possible, it's not always possible in some of the contexts in which we work. A lot of my research is on low and middle income countries. And by asking certain questions, we can actually put people at harm's way. So we have to think about which questions that we're going to ask. Often as well, a lot of my work doesn't involve biological sex. So I have to ask myself, is it appropriate for me to even ask about someone's biological sex, right? In a certain instance, if it's not relevant to what I'm doing, almost everything, gender is usually what is relevant, a person's gender identity and gender relations. So next slide, please. So let's move on to the first of the 3 sort of tools or activities that I'm going to be focusing on today. The first is data disaggregation. And data disaggregation, and this is important, is really just an entry point to explore inequities. It shows where they might be. Disaggregating our data by sex and gender, I would argue, is a component of gender analysis, but is not fully gender analysis. We can see where gaps exist, but we can't really explain why those gaps exist without asking additional questions. Next slide. So again, data disaggregation as an entry point. It allows us to measure potential unfair differences between and within groups. When I'm saying between, I'm saying like between men and women, maybe within groups, brings in that intersectional lens, because we can't treat all men the same, and we can't treat all women the same, and we can't treat all gender minorities the same. And Cara's already explained why that is, because of different identities and inequities that we might experience. So it's different from data aggregation, and Sabra actually really beautifully showed this in a diagram about aggregating versus disaggregating our data, and how we can miss really important differences if we're aggregating data. It can show overall trends, but really masking differences between and within subgroups. So disaggregated data is meant to act as a trigger, encourage deeper reflection. But we still can't really explain why differences exist. Next slide, please. So here is a graph that looks at new HIV infections in Sub-Saharan Africa by age and sex. It should say by age and gender, actually. And here's an example of how a lot of people conflate the two, and this is from UNAIDS. Hopefully now they do use right terminology. What I would like you to look at this graph and answer this question: where are there sex, gender inequities between and among women, men, boys, and girls? Where are the biggest gaps that we see? And you can type that into the chat box. So the blue are the males and men, and the green are women. Yeah, Sabra says after puberty and young adults. 15 to 24. Jay says it's big differences. Yes. So I like this slide because it is actually presenting intersectional data, right? We're looking at age and gender here. We're not just looking at age, and we're not just looking at gender. And if you were just to look at one or the other, you would miss this big difference, right? And if you were most interested on the number, like where the most people are being affected, we might be interested in the 25 to 49 range, right? But if we're interested in where the biggest inequities are, we would be interested in the 15 and 24 range. And I'm going to come back to this in a moment. So we're going to park this and we're going to come back to start thinking about explaining why these differences might be here. Next slide. So moving on to our next tool is gender frameworks as analytical guides. So I always use a gender framework to help my thinking when I'm integrating a gender lens. And these really help to organize our thinking and frame our work, our questions, identify variables if we're doing quantitative work, and conduct analysis. Next slide. There are a number of frameworks out there. I'm going to show you two today. One is the Chipago gender analysis framework, and what I want you to draw your attention to are the domains in the middle, in the circles. So what gender analysis frameworks really do, or gender frameworks, is they show us or identify the ways in which gender power relations can manifest as inequities to create unfair differences or differences between and among men and women. So as you see in the orange, you've got access to assets, you've got beliefs and perceptions, practices and participation, institutions, laws, and policies, and then how power is underlying all of that. Next slide. Here is another framework that is very similar, but slightly different. But again, thinking about asking the question, how are gender power relations, how might they be manifesting as inequities? And this one says by asking who has what, so access to resources, who does what, roles and practices, division of labor, how are values defined, norms, beliefs, perceptions, and who decides rules and decision-making, both formal and informal here. So what this does is kind of unpack the different ways gender power relations can manifest as inequities. And if you saw in Cara's presentation, she talked about gender roles and gender relations. You can see how that maps on here. I do like to look at it, like looking at the interrelationship between these factors, because it's sometimes very hard to unpack and untangle how the difference between a norm or a role or what impacts something else. And this helps me to really think through that relationship. And then as you can see at the bottom, how power is negotiated and changed if we're thinking about challenging and changing inequitable gender norms, roles, and relations. So I use this really as to frame and to help brainstorm in my work. Next slide. So gender analysis questions, and we're actually going to be bringing this stuff together now. So gender analysis questions examine why and how gender power relations cause inequities between and among men, women, and people of other genders, and how this can shape health and health systems needs, experiences, and outcomes. So next slide. So gender analysis questions, they can be sort of broader analytical questions, but they could, that we then incorporate into our data collection tools, whether they're qualitative or quantitative tools. And sometimes you might need multiple questions in your tool to answer a broader question. So if you're looking about the access to resources, you might be interested in if the extent to which women have access to financial resources. And there might be multiple questions that you have to ask to find that out, because there's different ways to get financial resources, for example. And that we often therefore use proxies to get at this. Often when I'm looking and exploring gender inequities, I'm not actually ever using the word gender in my tools. I am asking, and Cara presented different things that could be proxies, things around like education, income, employment, decision. Gender power relations are so multifaceted. And this is why we use gender frameworks, to ensure that we're thinking about the different ways gender power relations manifest as inequities, thinking about the interrelationship of them, and that we're not potentially privileging one over the other. Next slide, please. So again, coming back to this graph, what I want us to do is think about, like, apply this gender framework and apply these gender analysis questions to start to try to think about, especially the 15 to 24 age range, why are we seeing this difference? Why are we seeing this big gap? So next slide. So here's the gender analysis framework. As you can see, we've got access to resources, division of labor, norms, rules, and decision making. And if you can, just write in the chat box, you can choose any one of these gender domains that are taken from the gender framework. And can you think about anything, any gender consideration that might help explain that big difference, that the HIV incidence is much higher in young adolescent and young women compared to adolescent and young men. And it's okay to make assumptions here. We often start with assumptions, but then we find the data to answer those questions. Anyone have any ideas? Jay says power relations, ability to negotiate safe sex, access to condoms, non-consensual relations. Cara says Manuela, women having sex with older men. Jen, care utilization, appropriate education. Yeah, these are all, great potential reasons, how gender norms, roles, and relations might be affecting that difference. So next slide, please. Wendy says poverty, sex work as well. So here, and I think a lot of you covered some of these, and this is not exhaustive by any means, but here are some illustrative gender analysis questions that you can ask and then incorporate into your tools to help and try to explain or find out what is the cause of that gap. And gender power relations are extremely context specific. So what it means to be a man or woman in one context is going to be very different than in another. So just because it's one way in one country or context, city, doesn't mean it's going to be in another. So that's why we incorporate these questions to help to understand and explain those sort of sex and gender differences that we might see. And then I bolded potential proxies that you might use in your surveys or in your qualitative tools to help unpack this. Next slide. So gender analysis in the end really helps us to identify why and how inequities exist, so root causes. So sex and desegregated data helps us see where there might be gaps, where there might be inequities, but not why. Gender analysis really helps us explain why. And then when we know why, we can start to address why in our policies and in our programs to improve health outcomes and livelihoods. We can also then, use this to start to challenge or change inequitable and or harmful gender norms, roles, and relations, and that's gender transformative work. Not all research and interventions is going to be transformative, nor does it need to be, but it is something we should be striving for long-term sustainable change. By incorporating this lens as well, we're ensuring that our projects and programs are not perpetuating existing gender inequities. Often when we're gender blind, we're treating everybody fairly, for example, we end up being gender unequal by unintentionally actually perpetuating a harmful norm or harmful gender roles and relations. So by thinking through this from the beginning, we can prevent that. And then overall, it helps us to improve health outcomes and do better science. Next slide. And here I have on this last slide just some additional resources for you. So we've got the Gender Analysis Toolkit for Health Systems. It's a really interesting, really great resource that kind of really outlines how one can conduct, they call it gender analysis. I refer to it as gender situational analysis. Like you can go into a context to understand how gender norms, roles, relations, and inequities are playing out, and then work through how that might affect your research or your program. On the left is a toolkit that I helped to develop with TDR from the World Health Organization about incorporating intersectional gender analysis for research into infectious diseases of poverty. And in that pyramid I showed you is actually in this toolkit. It goes through the different activities. It's not exhaustive. I'm always adding things. I'm always changing things. I'm always finding new ways to explain things and new ways to do things. But I find this toolkit to be quite helpful to think through the different steps in research and think through how one would incorporate a gender lens. So I'm going to stop there. I did see there was a question from Danette, and I didn't want to ignore it. Danette says, if we're going to specify transgender, I'm called to also specify cisgender. This seems to be at the service of more inclusivity and encouraging cis folks to be more aware of their own gender identity instead of only emphasizing it for trans folks. Yeah, I absolutely don't disagree, Danette. I think that, there are different ways to ask about one's gender identity, and I've certainly seen questions that include cisgender. Sometimes you can have a very long list, and we need to think about what we include. Sometimes asking about the biological sex assigned at birth and then asking about gender is a way to identify and ask about transgender people without explicitly asking about it. But again, I always ask, do we need to know someone's biological sex? So there are different ways to do it. It's a way to ask, and it's up to us to think through what's the most appropriate, what's the most useful, given my context, my time, my resources, things like that. Great. I know I don't want to take any more time, so I'm going to hand it over to Wendy and Jay now to bring it all together.
Great. Well, this is so exciting to have an amazing group here today and to really kick off a lot of our efforts to bring together researchers to be able to talk about some of these complicated issues. So I'm really pleased to do this talk. We're going to be a little faster, I think, than the others, but I'm pleased to do this talk with Dr. Jay Vaidya. We are both in the Division of General Internal Medicine in the School of Medicine, and we're going to tag team, so we'll go back and forth a little bit, providing some examples of epidemiologic and clinical research and how we think about sex and gender. So you could go ahead with the next slide. So I really like this figure from Janine Clayton at the Office on Research on Women's Health, showing the translational pathway. And for us, we're talking more about clinical research here, but a lot of my work is really centered in healthcare focused research, on implementation research. And then many of you said you're doing population health. And I think that's really sort of the next step for us to think about how do we translate what we're learning about sex and gender-based research into interventions that we use for practice and policy change. So our focus is really going to be on some examples related to clinical and epidemiologic research. You can go to the next slide. So this is from the Lancet series on gender. I think that we all highlighted this in some ways in our talk, but clearly in epidemiologic research, we think about gender as a social determinant of health. And I think it's important to put it in that context because there is so much attention right now around what social factors drive how we access health care and the types of outcomes we have, health-related outcomes we have. And so I think it's important that we think about all of the things that Rosemary said in terms of our social position and that gendered pathway to health in terms of differential exposures, and then that relates to how we do our analyses. And the other thing I'll say about this is it really shows that life course approach. So you can see that along the bottom. And that's another thing that's really important, I think, in gender analyses, is that we think a lot about how we age and the different exposures that women have compared to men across the life course. So go ahead, next slide. So we're going to talk about considerations in the design, conduct, and reporting of research. We're going to be brief, and if anyone has questions after, feel free to ask. So next slide. So I wanted to talk about a clinical example that I actually saw as near and dear to not just the hearts of me and Jay, who are your presenters, but there are some cardiologists here today. And there are a lot of sex differences and gender differences related to cardiovascular disease outcomes. And we know that overall the mortality burden for all of cardiovascular disease is greater in women compared to men. And there are differences by sex, by gender across the entire clinical spectrum, from the time that we're diagnosed with heart disease to the types of treatments that are offered, the types of treatments that we receive, the effect of the treatments, and then the clinical outcomes. And so there's a lot of, anybody that's interested in this area, there's a lot of research being done here over many, many years. And we're going to highlight some of the approaches that we might take to look at some of these sex and gender differences. Next slide. So the first is really a question for you all. If this is a little bit of a brainstorm. So when you know, so knowing that there are differences in cardiovascular outcomes, why do you think these exist? So what are some of the factors that, if you were designing a study to look at these factors, what are some of the things that you would want to look at? So put them in the chat. Some of these things that you think we could measure and assess, or maybe things we can't measure yet. Okay, so different symptoms, so different presentations for how women and men might present with let's say a heart attack or other cardiovascular diseases. Good, that's good. Anything else? Okay, so different presentations over the life course, so younger women compared to older women compared to younger men and older men. Education, how providers are educated, how they respond differently to men and women in clinical settings, that there could be biases. Michelle Kaufman said stress levels. I think that's a big one. Different behaviors, compliance to meds, types of treatments, behavioral risk factors, different symptom reporting is another one. Good. So I think we have some of them out here. Social support, that's good during treatment. Yeah, so mechanistic ones, the biologic factors, how treatments might differentially impact men and women. Good. Okay, so let's go to the next slide. Really, I think there needs to be an arrow in the middle here, sort of showing that there's this intersectionality, and I tried to do that with that little Venn diagram in the middle, but we know that there are all of these biologic factors that drive sex differences, and I'm listing some of the ones that you mentioned, but there are many, many more. So, we talked earlier about the hormonal milieu, response to stress, but clearly exposure to stress, and how we differentially respond to that could be in either category, either the gender difference or the sex difference, how we respond to medications and other treatments, the types of side effects that we might have. There's a lot of evidence that statin medicines are different in men and women, and that women have more side effects to the types of statin medicines than men do. And so whether that drives adherence and other things, and statins are the medicines that we know reduce cholesterol and prevent heart attacks. There are age differences. There's a lot of differences in comorbid conditions. Jay and I are doing a study right now looking at differences in cardiovascular outcomes in people with diabetes. And we know that diabetes differentially impacts men and women, and cardiovascular outcomes are sort of the #1 causes of death in people with diabetes. So it's very important to look at these comorbid conditions. And then there's been a lot of studies looking at other biological risk factors. So for example, cholesterol levels, are they different between men and women? And they are, and trying to understand why and does that matter and how. And then Rosemary did a beautiful job going over all the social and cultural factors that we think about. And these go on and on, but we're just highlighting a few. So access to care, treatment preferences is something that has been examined. So when there are treatments offered, are there differences in how people respond to wanting a treatment versus refusing a treatment, or deciding to take something every other day or every third day instead of taking it, daily. We already talked a little bit about bias. Gender bias still exists. And there's a lot of biases all the way from diagnosis to how we counsel patients to the types of treatments that we might offer. There's exposures to stress, violence, and lots of other stressors in our lives that are different across genders. And then we're going to highlight the example of looking at inequities. And this relates to Rosemary's presentation, where she talked about access to resources like education and access to income. So that's the example that we're going to focus on. So next slide. And I'm going to pass this to Jay to go through this example, and he's going to pass it back to me. So go ahead, Jay.
Thanks, Wendy. Let's design a study. So this is a little back and forth. I'm going to be looking at the chat function. So the question, maybe this is the field that we are working in this example. Does higher education relate to less heart disease? Deliberately, this statement does not have sex and gender differences in the problem statement. But I'd like us to consider why we should assess for sex and gender differences in this research question. I want you to refer back to Dr. Tannenbaum's, Cara's talk, where she said the first thing is not not how you present your analysis, but how you plan the study. So please start typing in your chat, why should we assess? I'd also like to see if basic scientists give us some insights, because this sounds like such a clinical population level question. So just to try to say that it's, we have to, when we are studying, we have to look over the continuum of all our fields. Why would we assess for sex and gender differences for this research question? We have Rosemary gave us some thoughts about this. Wonderful, wonderful. Exactly like Cara said, that's where you start. Yeah. Yeah, higher education may be associated with better eating, exercise, physiologically better shape. People with more education might know more about prevention. Yeah, excellent, excellent. Next, please. So one of the things I would like to say is that while we are planning the research, we should have a very broad lens. We have more answers here: higher education, better jobs, better access to healthcare; higher education, better care. I think Wendy and I are so used to reading just the population health literature and clinical literature, but we should also think of basic mechanisms. You'd say, well, it's sex and gender because it's a human study, and so Cara has told us don't use the word gender in animals. However, there may be things that we can understand about sex in animals which may help us, which we might like to translate. So you could say animals don't have educational attainment. However, there might be studies in social status. Behavioral biology has animal hierarchy studies. And perhaps that shows sex differences with disease. There's a role of stress. There may be studies about stress, with sex differences in stress in animal studies. Just for completion, if you're on the other side, if you're doing a, this is better handled by by Sabra, Dr. Klein. If you're a basic scientist, you might also want to know whether the prevalence of heart disease and social hierarchies differ in men and humans. And after we have done a lot of this research, you may find out there's an absence of evidence. That is also an important thing to know, because that tells you that there's discovery potential. We have more here. Access to treatments may differ. There's an interaction between social norms and employment status that might differ by gender. All of these. Okay, next, please. Let's follow one study through a little more. Let's next. The main thing is we have to collect the data. If we don't collect the data, we won't be able to disaggregate. And again, as Cara has told us, the disaggregation of data might only be the beginning. We are really trying to find the mechanism. So if we don't collect data about what might be the mechanism of the sex difference, there is no way to study what we don't collect. I'm going to follow through the example of a single study. Fujino et al., please next. Which they published in 2005 from a Japanese study. They were looking for decades of data, but that's only, so they were able to separate men and women. They did not have very much about gender roles and stuff like that, but they had some proxy variables like occupation. In any case, we see in this bar chart that when we compare the blue low education bars versus the reference that's at 1 of people with high education, men have slightly higher risk of heart disease, not significant, and women have a much higher, low educated women have a much higher risk of heart disease. And so this is the kind of disaggregation that's only possible if the data were collected. And then again, how much mechanism study can we do? So collect the data is the point when we are doing this in the planning stage of the study. We might be planning secondary data analysis. There are sources like the National NHANES. We again have to look at the data quality that may exist, because first disaggregate and show there's a difference, and then show for mechanism. Next, please. We have already talked about this. We don't have as much time. So just because a single study may not have enough power, next please, we will be helping researchers into the future. This was a meta-analysis done in 2017. This used the Circle study from 2005. And even though they did not have the power in the 2005 study to do a statistical interaction analysis, by 2017, there was enough data collection to do this and find a sex difference in this association. Next, please. One of the things I'd like to highlight from the paper is that of all of the papers they looked for, they had to exclude 136 papers. Biggies out there. 48 did not provide disaggregated data, no sex-specific relative risk, and 21 were performed only in men, only in women, or in populations that were somehow non-representative. Again, intersectionality of representativeness. So when we design, let's be representative. Next, and back to Wendy.
Great. I know we're trying to fly through so that we're mindful of everybody's time. I think we only have a couple of minutes left, so if you could stick with us. So once we do our analysis, we write up our manuscript, we're really thinking about how do we report sex, gender, or both. And this is a paper that Cara participated in, which I think is great, and does give some nice examples of suggested approach for your table 1, right? So where you're really presenting your counts. And we could think about, this was years ago, so I'm sure now there's even more categories that she presented in terms of how we want to collect our data and present our data by gender. But it's really important, I think, that we think about how we report. And I appreciated, Cara, in your presentation that you're starting to do more work with journal editors on how they're going to handle how we want to report intersectionality and report sex and gender and all of these analyses in our papers, because obviously this is where the challenge is too, is getting them familiar with what we want to report. So I really appreciated this. Next slide. And I think it's really interesting that the author gender is highly related to whether they are paying attention to and reporting sex and gender in their analyses. And so one of the strategies actually for enhancing the type of research we do and enhancing the quality of research we do in sex and gender research is actually to enhance our equity here in academic medicine. And gender equity is a focus of a lot of what we're doing here at Hopkins. And this will actually improve the quality of research we do as well. So I think it's important to think about that. Next slide. So I want to end on a positive, exciting note by sharing with you funding opportunities to support this work. And as we come together and think about creating this as a network here at Hopkins, I want us to, think about how we support each other, how we grow this, and where are the funding opportunities that will bring us together. So next slide. So many of you know the Office on Research on Women's Health at NIH has been supporting a K-12 program, and this is an internal K program that Johns Hopkins has been fortunate enough to have, and we are now in our renewal, so we are in our second phase of this. These Birch programs, as they're called, are all over the US. It creates a really nice network of women's health, sex, and gender researchers, and there will be a call at some point, probably early next year, for more junior faculty to apply for this. So just keep an eye out. And I think it's a really great program that we are fortunate to have at Hopkins, and we're looking to sustain this. Next slide. Many of you have seen this. I think this gets announced about once a year by the NIH, also through the Office on Research on Women's Health, where they are in favor of supporting administrative supplements for research on sex and gender differences. And then there have been other RFAs that are similar to this that come out, or FOAs, I should say, that come out from NIH on supplements. So pay attention to this in terms of adding on to existing studies where you can enhance your sample size, you can add on additional analyses. Next slide. So Sabra mentioned that she is the PI, and we are really fortunate to have a SCORE here. This is a specialized center of research excellence on sex differences. Ours is focused on sex differences related to immunity and specifically looking at aging. And you can go to the next slide. And one of the things that we offer through our SCORE is an opportunity to apply for these pilot awards. So we are in our third year now offering pilot grants or seed grants. They are $50,000 each. And we announced this RFA just a couple of weeks ago. So it is open and it is meant to be broad. So we are looking at sex and gender and intersectional research. The research must broadly involve the immune system or inflammatory conditions, but we listed many of them here, and we are very open. We think that probably everything involves the immune system or inflammation in some way or another. And so certainly if you're unsure, you can reach out to me, and I'm happy to confirm that likely you could make your science fit with this. So we are looking to get lots of applications, and we are growing this network of researchers through our pilot awards and our career enhancement. Next slide. And then I highlighted this, but really promoting gender equity in research is of high importance as we want to advance the field of sex and gender research, and I see them as very closely linked. So promoting women's careers in academic medicine is part of our mission here at our Center for Women's Health, Sex, and Gender Research. And I think we're going to end on this very positive note about promoting good things. So next slide. Yeah, so just some more resources, and I think I could probably close, Sabra, because I know we're 4 minutes after, and I just want to say that on behalf of our Center for Women's Health, Sex, and Gender Research, I want to give an applause to Dr. Tannenbaum and thank you so much for joining us. Your talk was incredibly inspiring and hopefully will bring us all together in this network that we want to create here at Hopkins. And I really want to thank our audience. We started off with 62. I know that we have had some attrition as we hit the very end, but it really was a chock full 2 hours and great talks, very inspiring. So thank you everybody for joining us, and we look forward to doing it again.
Thank you.
Bye.